I want to first of all thank Senator Blunt, Senator Murray, Representatives Moulton and Fitzpatrick for sponsoring our briefing this afternoon. And I want to thank everyone that's here for taking time out of your day to come and listen to what we have to say. We're Dysautonomia International. We're a patient advocacy group formed, an all-volunteer organization formed by patients and caregivers to advocate for the dysautonomia community. Our mission is to provide education to our patients, to physicians, and to the general community, and to promote awareness of a disorder that is not at all rare, but very rarely known about. The most important part of our mission is to promote research into these conditions to help our patient community live more fully productive lives. So again, thank you all for being here. We're going to start with a brief video that introduces what our organization has done in the short 5 years we've been in existence. I'm sorry. It's a short video about POTS, which is the predominant illness among the patients in our community, postural orthostatic tachycardia syndrome. Hopefully it'll be familiar to you. You'll recognize, I'm sure everyone probably knows someone that has some of these symptoms. And then I'm going to turn it over to our organization's president, Lauren Stiles, to open up the presentation. Thank you.
POTS.
Postural
orthostatic
Tachycardia syndrome.
POTS is a syndrome that really has two criteria, but a lot of associated features. People with POTS have orthostatic intolerance, that is, they don't tolerate standing up, and they have an exaggerated orthostatic tachycardic response. Their heart rate goes up more than it should when they stand up.
When you stand and gravity is displacing blood downward, your brain senses that and makes your heart beat faster, makes it beat more forcibly, and tells the blood vessels in the lower half of the body to become 3 times tighter than what they were before. That tightening pushes blood upwards towards the brain. And in POTS, they're unable to either make or maintain that tightening of blood vessels. And so blood is pulled by gravity downward. The brain, trying to compensate, will then tell the heart to beat harder and faster, and frequently it compensates enough to prevent the person from losing consciousness, but nonetheless is unable to maintain the same levels of perfusion or blood flow to the brain and other organs that were previously present.
The problem with POTS is that it is a syndrome, meaning that it encompasses different symptoms. And people do not only complain of their heart racing, but they can complain of a zillion other things.
Shortness of breath, tightness of chest,
lightheadedness,
fibromyalgia,
dizziness,
Malnutrition,
brain fog,
stomach problems,
light sensitivity, sound sensitivity,
GI tract shut down,
headaches, random body pain, sometimes everywhere hurts, fainting, heat intolerance,
blood pooling,
irritable bowel syndrome,
new onset allergies,
fatigue,
tingling.
I think there's about 100 more.
As you see, it's almost every organ of the body that is affected by this constellation of symptoms. POTS is not an isolated syndrome. It is part of a continuum, of a spectrum of conditions that range from very mild to very severe. And the common link is the autonomic nervous system. So for this reason, we put POTS as one of the major manifestations of autonomic dysfunction, or what we also call dysautonomia.
Although originally we only had a very simple set of criteria to diagnose, and now we realize that comes with a whole package, and most patients have the whole package.
It gets treated in a variety of ways. A lot of us as physicians have our own individualized approaches. I try and look at the most important factor contributing to that person's POTS.
Just because someone doesn't look sick doesn't mean they aren't sick. A lot of the patients actually look like young, healthy women. I think if someone was missing a leg, I don't think anyone would question that something's happened and probably have more empathy. I think that sometimes is tougher for patients with POTS because they don't visibly look sick.
How many people have POTS? In all our experiences here, we all can say that we are overwhelmed with patients who have this condition.
We started to recognize the first cases of POTS around 1993. Of course, at that time, lots of doctors thought this doesn't exist. But as the time went on and on, people realized, no, this is real, and there's a diagnosis for it. And now it's undeniable. We have major centers involved, major university programs that are really in the front lines of research.
We're going to hear from 3 people this afternoon. The first speaker is Lauren Stiles, the president of Dysautonomia International. Lauren developed POTS after receiving a concussion snowboarding in 2010. Since then, she has been an outspoken advocate for individuals living with POTS and other autonomic nervous system disorders, and is one of the co-founders, along with myself, of Dysautonomia International. Next, we'll hear from Dr. Glen Cook. Dr. Cook is currently an assistant professor in the Department of Neurology at the Uniformed Services University School of Medicine, and he's the director of the Autonomic and Clinical Neurophysiology Lab at the Naval Medical Center in Portsmouth, Virginia. And finally, we'll hear from Dr. Jeff Boris. Dr. Boris has been at the Children's Hospital of Philadelphia for 10 years, where he founded the hospital's postural orthostatic tachycardia syndrome program and currently serves over 850 POTS patients. So join me in welcoming all 3 of our speakers today.
Thank you so much, Ellen. I wanted to thank you guys all for coming today. We're really excited. We're a fairly new organization, and this is our first time holding a briefing, so we're pretty glad we've filled up the room. Let me find my slides here. So we're switching around the agenda a little bit. I was going to go first just to give you sort of the flavor of the patient experience, and then Dr. Cook and Dr. Boris are going to give you the more medical information since there are doctors. Okay, so life before POTS. I'm an attorney. I was working at a firm on Long Island, and I'm happily married. I was very athletic, snowboarding, surfing all the time. I had a great life. I was blessed. I never really had any health issues. I didn't even have a primary care doctor when I first got sick. But all of that changed with a snowboarding concussion in 2010. I woke up 2 days later, and I couldn't walk. And it wasn't because my leg muscles weren't working, but it was because my body couldn't regulate my blood pressure and my heart rate. And that's controlled by the autonomic nervous system. And it was so severe that I couldn't even get myself a glass of water. I became fully bedridden within 2 or 3 days of the concussion. So I remained bedridden, unfortunately, for about 2 years because doctors couldn't figure out what was wrong with me. It was pretty obvious to me that this was somehow caused, whatever I had was caused by the concussion. But the symptoms that I had really weren't typical concussion symptoms, and I just kept getting misdiagnosed over and over and over again for 2 years. I live in New York, so I went to some of the best hospitals in New York City. I saw the chairman of neurology, the chairman of cardiology, people who were really brilliant doctors couldn't figure what I had. They couldn't figure out what I had. So my symptoms, fainting pretty much every time I stood up for more than a few minutes, which is probably more severe than the typical POTS patient, but there are a lot of POTS patients that have this problem. Feeling like I was going to faint all the time. Stabbing chest pains. We're all told, if you have stabbing chest pain, you should go to the ER. Well, what happens when you do and they don't know why you have stabbing chest pain? So they send you home. Severe shortness of breath, which I still have, so you might hear me getting a little short of breath during my talk. That's just part of my symptoms. Choking on food and drink so often. Your autonomic nervous system controls your GI tract. So I was having such a hard time swallowing that I lost 60 pounds without trying because I couldn't eat. And I wasn't a very heavy person to begin with, so this was pretty dangerous to lose about a third of my body weight or more. My hair was falling out from malnutrition, and I could barely read or write or watch TV because my pupils were dilated and they were not focusing properly. So it was really hard for me to concentrate. So I basically laid in bed, and that is not my personality at all. I was such a doer and such an active person. When I saw doctors, some of them tried to help and they just didn't know what I have. And then a lot of doctors, I guess the instinct is when you don't know what a patient has, you kind of turn it around and blame them for the problem. So I was told, you're just hungover, which I wasn't. I was told, maybe you weren't cut out to be a lawyer. Just go home and have a glass of red wine to relax, which I thought was funny because the first doctor thought I was a drunk and the second one was telling me to drink, but neither one of them were right. You're doing this because you're 31 and you don't have babies yet and you're just trying to get attention from your husband. Wow. That guy's really lucky I was bedridden because I would have kicked him in the face otherwise. He was not my doctor 5 minutes after that. And then my personal favorite, you're deconditioned because lawyers sit at their desks all day. So this is me sitting at my desk all day, surfing and whitewater rafting. I was not deconditioned when this started. I was on a 7-day snowboarding trip up at Mount Snow, Vermont. But I did become deconditioned over time because when you're bedridden and you can't walk, naturally your body you're gonna lose muscle tone and you'll get deconditioned. So the economic impact on my family was horrible. If I had been diagnosed early and got on the right treatment early, that probably wouldn't have happened. But I couldn't work as an attorney anymore. I was literally bedridden. How am I gonna be an attorney? And not being able to read and write kind of doesn't work as an attorney either. My mom had to take early retirement to move in and take care of me, even though I was a married woman, because my husband had to go to work every day to pay the bills. And he took on a second job, consulting. Thankfully, he had the ability to do that. I had $80,000 in out-of-pocket medical expenses in 2 years, and that is with top-of-the-line Cadillac insurance. I had private Blue Cross Blue Shield, best insurance money could buy. And my insurance covered all of the treatments and tests that my doctors ordered, but that was still my out-of-pocket. And I know that most Americans can't afford that, so it really makes me worry what happens to all the other patients who can't afford all that care and trying to find a diagnosis, you know? This whole concept of me not being diagnosed for 2 years is actually short. A lot of our POTS patients, as the doctors will tell you later, suffer for years without a diagnosis. So we depleted our savings pretty quickly, and I actually had to sell my car and some of our other belongings just to pay the mortgage at one point. It was really scary. Losing your physical health is bad enough. Losing your economic stability is scary. And then also, I kind of felt like I lost my identity. If I'm not Lauren, the surfing lawyer, who am I? When am I? I'm just laying in bed every day. This is not really a life. And I was pretty scared because I had all these terrifying and painful symptoms, and no one could tell me why. I went to doctor after doctor after doctor and got no answers. And then I started to feel a little hopeless because people who were good doctors were giving up on me. They'd say, maybe you're just going to have to get used to feeling like this. I was bedridden at 31 years old. How am I going to get used to that? And I just said, no, I'm going to keep pushing. So about 9 months into my bedridden journey, a neurologist at Cornell in New York City, which is one of the best hospitals in the country and definitely one of the best in New York City, they misdiagnosed me with neuroendocrine cancer because surprisingly my symptoms matched that of this certain type of neuroendocrine cancer called carcinoid. But it turns out they were wrong. Thankfully, I did not have cancer. I figured out what I did have while I was laying in my hospital bed at Cornell because I just kept Googling my symptoms like crazy, which every doctor tells you not to do. Don't go to Dr. Google. Well, Dr. Google probably helped me get diagnosed. So the doctors at Cornell eventually confirmed that I did have POTS. And then I thought, awesome, I'm diagnosed, I'm gonna get treatment, I'm gonna get better. Nope. They discharged me from Cornell because they didn't know how to treat POTS. They said, we don't have anyone here who knows how to treat this. This is one of the biggest hospitals in the country. There's like 2,000 beds in their hospital. It's huge. They didn't have anyone on staff who knew what this was. So I went to a different center at NYU that does have some some autonomic nerve disorders experience. And they told me there's nothing we can do for you people, not a very nice way to refer to a patient population. Get some exercise and see a psychiatrist so you can get used to feeling this sick. When I saw them, I was in a reclining wheelchair. I couldn't even sit upright in a regular wheelchair without fainting. So I was basically laying down 24/7. I decided if I couldn't find help from doctors, I was gonna just have to help myself. So they started giving me IV saline, which did help my blood pressure, my blood flow a little bit better. So I actually was able to start reading. I know that sounds weird. Why would your blood pressure affect your reading, right? But if you're not getting good blood flow to your brain, you can't really think clearly. You feel like you have brain fog. So when that was addressed, I started reading POTS articles, like all of them, literally. I read every single article I could find on POTS. And so I got my primary care doctor to go through the standard POTS treatments with me, which the doctors are going to talk to you about later. And even with optimized treatment, I had maybe a 10% improvement. Instead of being bedridden, I was like couch-ridden, like I upgraded to the couch. And I could watch a little bit of Jeopardy or something, but I wasn't really like a functional human being. And doctors kept finding additional medical problems that are things I had never heard of before. I actually had this giant list of pretty serious medical complications that were above and beyond POTS. And I knew in my gut that this had to be some kind of underlying disease process that was causing all of this weird stuff. So I kept pushing and I kept pushing. And then 2 years into it, I finally got the proper diagnosis. I had POTS due to an autoimmune disease called Sjogren's syndrome, which commonly affects women and commonly causes problems with the autonomic nervous system, which is why it caused POTS. It also caused all of those other things on my long list of medical problems. So once we identified the Sjogren's, the Cleveland Clinic doctors put me on an immunotherapy drug to treat the Sjogren's directly, and my POTS symptoms dramatically improved. I'm not cured. I still live with disease, health issues every single day. But I'm here, I'm upright, I'm talking, I'm reading. I mean, you stop taking things for granted when you've been through that. And so I was trying not to get emotional, but I knew I would. Just be thankful if you can walk and read and, spend time with your family. Just don't ever take that for granted. So there are millions of other POTS patients who need the same answer that I got or a better treatment. And that's why we do this, because there's literally over 1 million patients in the country who have, many of whom are bedridden or wheelchair bound, who can't go to school, who can't go to work, and they really have no treatments. I mean, there are a few treatments, but they're not effective for the majority of patients. So this is why we need more research. The good news is there's a chart over to the left. There's more POTS research journal articles being published than ever before. We had about 80 articles published in 2016. But that's really not a lot. Compared to other diseases, multiple sclerosis in 2016 had over 5,000 journal articles published. Parkinson's had over 7,000 journal articles published because those diseases get research funding. Unfortunately, there's little to no funding for POTS research. The NIH has funded 4 POTS-specific research studies in the past 5 years, 3 from Heart, Lung, and Blood, and 1 from NINDS, the neurological branch of NIH. And there are a couple of other studies where POTS was kind of mentioned in the study, but it isn't really the point of the study. So to compare to other diseases, POTS gets 18 cents per patient on research funding, and that's if we assume there's 1 million patients. We actually think it's probably closer to 3 million. So that would be 6 cents per patient. And so MS gets almost $200 a year per patient for research funding. POTS gets 18 cents. And so it's no wonder that we don't have any really effective treatments for our patient population. The things that NIH considers, I'm sure there's many things they consider, but the disability caused by the illness. So POTS is similar in disability to congestive heart failure and COPD, except it's happening in young people. The quality of life in POTS is equated to the quality of life in end-stage kidney disease, people who are on dialysis for the rest of their lives. POTS impacts more people than multiple sclerosis. MS is about 400,000 Americans. POTS is the 1 to 3 million range. and Parkinson's impacts about 1 million, just to give you a comparison. The economic impact of the disease is huge. A third of these patients apply for Social Security disability, and about 65% get approved. And that's with Social Security really having no idea what POTS is. They've never heard of it. So the patients have tremendous healthcare costs. My $80,000 is an example of that, especially when you're misdiagnosed for so long, your medical bills rack up pretty quickly. And then, is there good research to fund? So the answer is yes. There's a lot of cool new things happening in POTS research that we hope that NIH will take an interest in and really start supporting this area of research more than they have. And we're grateful for the research funding we have, but we obviously need more given the scope and the extent of the problem. There's currently, there's a new international research registry, which Dysautonomia International is running with Vanderbilt University. We have over 4,000 patients currently enrolled. There's interesting research going on looking at autoimmune biomarkers in POTS patients and potentially immunotherapies that are used in other autoimmune diseases being used in POTS. And that's what got me so much better. So I'm hoping that will help some other patients as well. There's some new genetic and epigenetic research going on in Australia, where they've identified epigenetics are things that influence the way your genes are expressed and the way they function, or the way that proteins function. And they've identified an epigenetic problem that might be treatable with a cancer drug in Australia. So I would love to see that research happening here too. New skin biopsy techniques to help identify the pathological basis of POTS. There's a doctor up at Harvard who's on our board who is identifying a biopsy technique that can look at the autonomic nerves in your small blood vessels in your legs, in the skin. And this is useful in POTS and diabetic autonomic neuropathy and Parkinson's autonomic neuropathy. So when we fund POTS research, we're not just benefiting POTS. There are other diseases that sort of relate to this. Bioelectric medicine, which is pretty big. NIH has a new, I guess, a division or a department that's focused on stimulating the field of bioelectric medicine. GlaxoSmithKline had a $70 million investment recently. And this is stimulating the autonomic nervous system to influence the way that the immune system works. And we're hopeful that that will be something used in POTS someday. And then repurposing existing drugs that already have FDA approval for other diseases to use them in POTS. A good example is ivabradine. It's a drug that was FDA approved for congestive heart failure, but it works in POTS too. The problem is, because it's a new drug, the insurance companies don't want to pay for it. It's very expensive since it's a new drug. And so they deny it. And we don't have a way right now to help those families get access to the drug because we don't have enough research really conclusively proving that it works. So that would be something that would be great to fund. So here's my ask from your congressional offices. It's kind of a long list, and I can't go into detail right now on everything, but I just want people to know that these issues are out here, and we want to follow up with all of you on this and see what we can do to start the ball rolling to advocate for this patient community. So federal agencies, we know that you don't directly tell NIH what to fund as congressional offices, but you can certainly, put in an inquiry letter saying, can you let us know what you're doing in POTS research? And NIH, they'll probably try to give you a really good answer, but it isn't much. And I think just hearing from members, knowing that there is an interest in seeing more would be helpful. Not just NIH, the Veterans Administration, Department of Defense, CDC. I've been told that Congress can direct CDC to do certain things if you provide funding. And we need an epidemiological study. The 1 to 3 million estimate is an estimate. There's been no major epidemiological study on POTS. We'd like to see an expansion of physician education on POTS, which might include investing in NIH fellowships. Dr. Cook is a graduate of the NIH fellowship program, and that's probably where you learned the most about autonomic disorders. And I think you also have your own fellows now, right? Or neurophysiology fellows. But this is an area where Congress can put some money into that to help train more doctors in the field. Center for Medicaid Services. CMS doesn't reimburse autonomic testing. The way you get diagnosed is with a tilt table test and some other autonomic testing that's kind of specialized. The doctors who do this are few, and there are very few of them. And it's because they don't get good reimbursement for autonomic testing, so hospitals and private practice doctors don't want to do this testing. They can't make money off it. They can't even get reimbursed for their costs. So only large academic medical centers do this type of testing, and even that is hard for them to get the resources they need because the testing isn't reimbursed very well. We would love to work with Social Security Administration to develop POTS-specific guidelines. Patients are waiting months or years for decisions because the decision makers don't know what POTS is. So maybe we could provide some guidance to let them know what it is and to maybe develop criteria for who's sick enough to get it and who's not. The FDA has a drug called midodrine that is used off-label to treat POTS. Midodrine was approved in 1996, but the drug company never submitted their post-marketing data, or they did and it wasn't sufficient for FDA purposes. And so in 2010, the FDA said, well, we're going to pull this drug off the market. And the patient community and the physician community who treat POTS and other types of dysautonomia kind of freaked out and said, no, you can't pull this off the market. This is a drug we all use. It's very safe. It's benign. We use it, and it works pretty well. So we have been advocating for FDA to make a decision on midodrine. They had a notice of hearing, and since 2010, they haven't held the hearing. So we need an answer on that, and hopefully an affirmative answer to keep the drug available to U.S. patients. There is no other drug that can do what midodrine does. It's not like swapping out, one steroid for another steroid. Like there's no alternative. And then last but not least, and maybe the easiest, is to use your platform to help us raise awareness with your constituents. Social media, if you have newsletters, local educational events for your constituents that we could partner with you on. So we have a team of patient volunteers who are gonna tweet this What is POTS video that we just showed to all of your member Twitter accounts. And we would love it if you could retweet it out and say, we attended a briefing on POTS today. It's kind of an easy thing to do, and it really will raise a lot of awareness. So thank you very much for your time. I'm sorry if I talk fast from New York. But we have up next is Dr. Cook, who's gonna talk to us a little bit more about POTS.
All right. Thanks, and thanks for joining us today and giving all of us the chance to share about this condition. I'm just curious, who came into the room today knowing that they have POTS or knows someone with POTS? Who walked in the room going, I have POTS or I know someone with POTS? Okay. And who, having been here, says now, wow, I didn't think I had POTS or know someone with POTS, but now I do. Don't go, oh, my cousin has that. Okay, look around. With the information that you get today, my bet is that a good number of you in the next few months will hear about someone and say, you know what? I heard something about this condition, and I think that's what you have. You'll come across this. This is not an uncommon condition. So a few things to share up front. So first off, I am here on an official duty activity, but what I'm sharing today reflects my own views, not that of any branch of the U.S. government. I am going to be sharing information that comes from some of the research protocols that we're doing at Naval Medical Center Portsmouth. And this is what I want you to walk away from the next few minutes having a sense of. First, what does a person with POTS look like? What do they experience? And you've gotten some sense of that from the video and from Ms. Stiles' experience. We're going to talk about some of the things that might cause POTS. What are the underlying problems? We'll talk about the diagnosis, some of the things that we do to figure out what's going on in someone with POTS, and we'll talk about some of the treatments that we use. So POTS, we just back up and talk about, well, what is this? So we use this acronym because postural orthostatic tachycardia syndrome is a little bit long to say. We're going to break that term down a little bit more, but we're going to say POTS. And talking about the experience of patients with POTS, I'm coming at this from the experience within the military healthcare system. So the military healthcare system provides medical care to a very large population within the United States. And as we talk about the military healthcare system experience, a lot of that is closely tied with my own experience. So I became interested in disorders of the autonomic nervous system, including POTS, when I was a third-year resident. We have an autonomic testing laboratory in Bethesda that was established about a decade ago at National Naval Medical Center, and it remained in operation after the merger with Walter Reed. And it was there that I got my first exposure. I went in saying, hey, what are you guys doing in here? Let me come learn. And I started reading the tests, and I realized that, hey, there's some really interesting physiology here, and hey, there's a really big unmet need here. So I went to the Navy and said, hey, Navy, I want to go get trained in clinical neurophysiology and autonomic disorders. And they said, all right, Glenn, that sounds like a good idea. And so they sent me over to the National Institutes of Health to train in the clinical neurocardiology section. And while I was there, we established a collaborative autonomic disorders clinic. So the first DoD autonomic disorders clinic. That was end of 2013 that we did that. And then when the Navy moved me down to Portsmouth, that clinic moved with me. We see about 60 new patients every year in our autonomic disorders clinic, and about a third of those patients have POTS. About 44% of our clinic population is active duty military, about 14% retired, and the rest are military dependents, so wives, husbands, sons, daughters. So that's a little bit about my story, but let me tell you a different story, the story of one of my patients. I'm going to tell you about Airman Barrington. That's not her real name, but this is her story. She's a 22-year-old young woman who was an athlete and competitive weightlifter, joined the military, and in basic training developed a cough, an upper respiratory infection, and had a lot of the same symptoms that you and I have all experienced: productive cough, low-grade fevers, not feeling well. And those went on for actually quite a while, and she was cared for at the local military clinic and actually seen in the local civilian hospital because of the length of her symptoms. No pneumonia or other disturbing condition was found, and eventually the cough started to resolve. But as that got better, she started developing some new symptoms. She started having a lot of fatigue, and she got dizzy when she would stand up. Eventually, she started passing out with standing up. And she went from being able to do very aggressive CrossFit type exercises to barely being able to do even simple workout activities, which obviously is not compatible with military service. She got tingling and numbness feelings in her hands and in her feet. And this went on for a little while, and she went from doctor to doctor until someone said, hey, I think I know what you've got. You need to go up to Walter Reed and be seen in their autonomic disorders clinic. And she got up to us, and when we saw her in clinic, she told us her story, told us a lot of the symptoms that she was having, the dry mouth that she was having, this tingling, the intolerance of standing up, the severe fatigue, the disturbances of sleep. But examining her, she looked very normal. If she were sitting here in this room, you thought she was a normal, healthy person. Until she stood up for a while and passed out, then you might have a clue. The only thing that we could pick up was that when she went from sitting and her heart rate was 88 to standing, her heart rate went up to like 118, 120. That was abnormal. So Airman Barrington's pretty reflective of the typical POTS patient that we see in clinic. So our average POTS patient is 27 years old, and about 80% of the patients with POTS that we see in our military autonomic disorders referral clinic have postural tachycardia syndrome. So when we talk about postural orthostatic tachycardia syndrome, well, what is that? So you heard in the introductory video two things. So number one, an intolerance of standing up. So an intolerance of being ortho, upright, static, and not moving. And with that intolerance of standing up, there's an excessive increase in heart rate. Heart rate goes up higher than it should. And because POTS involves abnormal activities of the autonomic nervous system, we call it a dysautonomia. So what is the autonomic nervous system? So that's that part of the nervous system that controls the things that you don't think about. At least you don't think about them until they go wrong. So control of heart rate, control of blood pressure, control of sweating, digestion, urination. These things that are automatic within the body. And it's not just a single system. These are multiple highly integrated systems that are also closely linked with everything else that we do. So closely linked with motor function, closely linked with the sensory input from our body into our brain, and closely linked with emotions. And because the autonomic nervous system is responsible for activities throughout the body, dysautonomias are very commonly whole body diseases. And because there's often not any outward manifestation of autonomic dysfunction, dysautonomias are very often invisible diseases. Like I mentioned, Airman Barrington, if she were in this room, you'd think there was nothing abnormal about her. And like has already been shared, dysautonomia is not just the not tolerating standing up. POTS is not just the not tolerating standing up. So people with POTS often have a lot of other things going on. So like Airman Barrington, many people with POTS have migraine headaches. There's a large overlap with abnormal joint hypermobility, shown on this slide as Ehlers-Danlos syndrome. Pain syndromes like fibromyalgia are very common, and severe fatigue syndromes are very common. Maybe 15, 20, 25% of people with POTS pass out or faint frequently. And these numbers have been replicated by other groups. So the numbers from the Children's Hospital of Philadelphia group reflect a very similar wide array of physical complaints. In fact, in their study, over half of their patients had at least 14 debilitating physical complaints. So what causes POTS? Well, this is the million-dollar question. And the first answer is it's not just one thing. So POTS is a very heterogeneous disorder. So what I tell my medical students and residents is whenever you diagnose someone with POTS, the next question you have to ask is why? You might not find the answer. In fact, very often we don't find a specific answer for a specific patient, but sometimes we do. For example, we've found that in our referral clinic, 1 to 2% of the new patients that we see actually have a hormone abnormality where they don't make enough cortisol. And that's treatable. And so we can get rid of their POTS. But that's much less common. We talked about the joint hypermobility, and that's seen in a good number of our patients with POTS. Many groups have shown abnormal pooling of blood in the veins of the body. And you heard about that a little bit in the video. And it talked about the fact that if blood's pooling down in the veins, it's not going to get back up to the heart, and the heart's not going to be able to pump that blood sufficiently to the brain. And that's going to cause feelings of distress. The heart's going to have to work harder and faster to try to make up for that. And obviously the brain's probably not going to work as well as it otherwise would, producing those symptoms that are often called brain fog. There's been an association of decreased blood volume with POTS. And as we look at those small autonomic nerves throughout the body that control those automatic functions, a good number of POTS patients have evidence of autonomic nerve destruction or dysfunction. In our clinic, about 2/3 of our POTS patients have evidence of autonomic nerve dysfunction or disruption. And these commonly observed physical abnormalities overlap with one another, not just in their occurrence, but also in the way that one may lead to another. There are other things that we see in POTS, but these are some of the big ones. And so how do we go about diagnosing someone with POTS and figuring out what might be causing their orthostatic intolerance and exaggerated heart rate? Well, the main component is what the patient tells us. So typically, patients will give us the story and tell us the diagnosis. That means that for us as physicians, we have to take time with the patients. We have to listen. Sometimes that's hard for people to do. But we have to listen. And oftentimes we have to use guided questions to probe what parts of the body might be affected. We measure the heart rate with standing. That's obviously key to the diagnosis of POTS. But you can see the green circle for testing is off to the side because the patient's story is what's most important in testing. And very often we will do screening tests of the functions of the autonomic nervous system. We'll do tests of sweat production. We'll do tests of heart rate control and blood pressure control. We'll do tests of what the heart rate and blood pressure do when the patient stands up. And that's a pretty typical battery of tests for an autonomic testing laboratory. And beyond that, we'll often do tests in the blood, tests of blood counts, tests of electrolytes in the blood, tests of hormones in the blood. We'll do other tests of bodily functions. So we might test gut motility. We might test bladder emptying. And in many patients with POTS, tests of the heart are very important, tests of heart rhythm, tests of heart function. But again, these are guided by what the patient tells us about what's going wrong. And like we talked about, in some cases, this leads to a clearly treatable abnormality. But in many cases, there's not a reversible condition. There's not an underlying process for us to interrupt. And so we focus on symptomatic treatments. So in Airman Barrington's case, by the time she came and saw us after about 9 months of symptoms, she had already learned that staying well hydrated and increasing her salt intake made her feel better. We set her up with a very low-key and gradually progressive physical training program where she worked with a physical therapist. And because her symptoms were severe and persistent, we used medicines that helped boost her blood pressure. And we can do that by making the blood vessels squeeze down with medicines like midodrine that you heard mentioned. We can do it by giving medicines that help boost the blood volume. And sometimes we'll use medicines to slow down the heart rate a little bit. Despite the treatments we use, many patients have ongoing symptoms. Additionally, while we may choose a medication or a treatment approach based on what the patient tells us, it's often an educated guess. So a few of the questions that we have are, how could we predict what patients are going to particularly respond to a specific treatment? For a given patient group, which treatments are going to be the best? So the information that we use to choose treatments is really based on clinical experience to a large extent and very small studies. There aren't any large studies of treatment therapies in patients with POTS. And these questions about treatment dovetail very, very closely with our questions about underlying causes of POTS and those things that we might do to even get more to the root of the issue. I understand that we're going to be saving questions for a panel at the end, and so I will turn the microphone over.
Good afternoon, everyone. Dr. Jeff Boris. I'm a pediatric cardiologist, so unlike the good Dr. Cook, who takes care of adult patients in the Department of Defense, I take care of kids at the Children's Hospital of Philadelphia. We're going to talk a little bit about epidemiology. Oh, God. So why does POTS happen? In whom do we see it? What starts it? And what do we see associated with it? So why does POTS happen? And this has already been referred to before, but basically, I don't know. We don't know what causes it. But it's probably a common final pathway from a lot of different insults and injuries and diseases. We don't have a good handle on it. In some patients, it's probably autoimmune. There's some autoantibodies that have been found in these patients so far with some of the research that's been done, but just because they're there doesn't mean that that's the cause, and that hasn't been necessarily proven at this point. And as already has been mentioned as well, this is associated with joint hypermobility, or what we sometimes call as stretchy joints, people who can do all kinds of funky party tricks. But that's not all the patients. So how many patients are we talking about? Well, Vanderbilt has already, as has already been mentioned, talked about an estimate of about 1 million to 3 million Americans. That includes adults and adolescents as well. At the Children's Hospital of Philadelphia, our official program started in January of 2014, although I've been there since November of 2007, so I'm coming up on 10 years. And when I first got there, I told our nurse manager in the clinic, I said, you know, I know how to take care of POTS patients, and her first response was, are you sure you want to tell me that? Because what happened was, as you can see in our numbers, the clinic exploded. We have now diagnosed over almost 900 patients with POTS in the 10 years that I've been there. So a few statistics. Last year, I looked at our program and looked at our patients, over 700 patients, 708 under age 18. It's the largest known clinical pediatric POTS database in the U.S. There's also a group looking, including Dysautonomia International, plus University of Calgary and Vanderbilt University. We're going to be looking at some of their data as well. It's referred to as the Big POTS study. It's an adults and a pediatric study where the large majority of them were over age 18 at the time of the survey. It was a web-based survey with data from over 3,000 patients. And finally, from some of Dr. Cook's data, the Department of Defense Military Healthcare Service. So in the Department of Defense, as you can hopefully see up here, the most common things that we see from an autonomic standpoint are in the first two lines, dizziness and syncope. Syncope is the fancy Greek term for passing out, right? So, I mean, I think we all know, either when we were teenagers or even now, folks who would be sitting for a while and they stand up and get a little bit of a head rush, right? And then that goes away. Some people are a little bit more affected by that, and some people are even more severely affected such that they pass out. However, there's number 3, and that's POTS, okay? So that's the third most common thing that's being seen in DOD. When we looked at race plus ethnicity from our database, the large majority of patients were Caucasian, with a very small representation from African Americans, Asians, and Hispanics. And that bore out in the Big POTS study as well, large majority Caucasian. From a gender standpoint, so who sees it? About 3.5 to 1 female to male ratio. In the adult literature, 4 to 1 and even 5 to 1 ratio has been seen for females over males. In the Big POTS study, 94% of the patients were female. Now, in the Department of Defense, for all autonomic disorders, about half patients were male, but that's all the autonomic disorders, so that's a lot of different stuff going on. As far as the age of presentation, for us, because we are a pediatric facility, the median age of presentation was about 15, with a range of course, 6 all the way up to 18. From a symptom onset standpoint, the median age of symptom onset was 12.3 years. So if you do the math, these patients have had symptoms at least, by and large, 3 years, plus or minus. For the Big POTS study, which is adult and pediatric, the peak age of symptom onset was 14, and over half started after age 18 years, right? So even though we see a lot of pediatric patients, there's a lot more adults who are getting this as well. So what triggers this? So some possible triggers. When we looked at this, about a quarter of our patients had an infection that kicked things off. So just like in Dr. Cook's anecdote, something like mononucleosis, a cold, upper respiratory infection, gastroenteritis, Lyme disease, sinus infection, skin infection, strep throat. 11% of patients had a concussion, just as Ms. Stiles' history. About 3% of patients had surgery or some sort of non-concussion trauma, like a fracture, that kind of thing. In adult studies, the incidence of infection as a trigger is about half of them. And as you can see here, just quickly, the infection type, again, upper respiratory tract infections and mono lead the way, followed by all kinds of other fun stuff. And then we talked about joint hypermobility before. In our study, over half of patients had joint hypermobility. Hopefully this photograph isn't freaking you out too badly. But these are the kind of party tricks that people do. And when we broke it down, there's a connective tissue disorder called hypermobile Ehlers-Danlos syndrome. And 22% had those, and the rest had what's called hypermobility spectrum disorder, which means you don't quite meet criteria for EDS. In the big pot study, 28% of patients had EDS as well. 5% of patients had an inflammatory disorder. So what does that mean associated with it? Well, so they might have had celiac disease. They might have had thyroid disease, thyroiditis, diabetes, Crohn's disease, cystic fibrosis, something called eosinophilic esophagitis. Autoimmune disease in the big pot study was seen in 16%, and there was a single local study up in New York that showed 20% of patients in adult patients. So some other observations, some other things that we've seen, that we see specifically in the pediatric population because this is germane to them. Rapid growth. The parents will say she had a growth spurt and all of a sudden she just felt awful. Hormonal changes. Onset of menses. Certainly something we don't necessarily see in the adult population, but certainly that happens in the kids. It can be familial. I would probably thumbnail at least a third, if not more, of our patients have a parent, a sibling, or a cousin affected by POTS. And as I mentioned before, it's probably a common end process. In adults, we see this after cancer, after diabetes, fibromyalgia, and a bunch of other disorders and diseases. And interestingly, these kids are often high achieving in academics, athletics, or both. So in some ways, they kind of come to the fore because it's a very long distance to fall. So it's a very huge difference in how they've been. But that doesn't mean that they're overachieving, and it doesn't mean that they have a psychiatric disorder because of the stress of what they've been doing. They want to get back to where they were. So now that you know what it looks like, we need to fix it, right? But there is a problem. And so people haven't heard of this. So here's some typical physician responses to encountering patients with POTS. I never heard of it. I've heard of it, but I don't believe it exists. I've heard of it, I believe it exists, and I hear my mommy calling. Okay? So a few providers are very helpful. In the big POTS study, the average number of doctors seen prior to diagnosis is 7, okay? And almost a quarter of those patients saw 10 or more doctors prior to getting their diagnosis. 3/4 of patients are misdiagnosed ahead of time. Or they'll do something that we've heard already today. They'll blame the patient. Over 3/4 of patients are diagnosed with a psychiatric disorder. Oh, it's anxiety. And they're like, I'm not anxious. Interestingly enough, in the big POTS study, only 30% of patients were being treated for a psychological disorder after they'd been given the diagnosis of POTS, which makes sense because the background incidence of psychiatric disease in the general population is about 25 to 30%. And 27% had a true psychological disorder prior to the diagnosis. So this leads to a delay in diagnosis, right? So the average delay in diagnosis from the big POTS study was 4 years and 2 months. Remember, from ours, it was about 3 years. So it's about the same, right? About a quarter or more than a quarter took over 5 years to get a diagnosis. And fewer than 20% were diagnosed by their first doctor. This leads, of course, also to disability. In the pediatric population, almost 90% of patients miss school days, with 44% missing almost more than 50 days of school, and almost a third missing over 100 days of school. Patients also getting out of college. 39% needed modified coursework, 38% delayed their completion, took a gap year, took a more time, and a quarter dropped out. And then there's the patients who are still at home because of their POTS, about a third of them. And interestingly enough, 31% of folks moved out, then had to move back in because of their disability. In the adult realm, patients out of work, as you heard from Ms. Stiles, about 80% have called in sick to work. 3/4 are unable to work for more than 1 week. Half missed at least 2 days of work per month. And about a fifth of them lost a job due to their POTS. So the loss of income, as has also been mentioned, is significant. 70% of patients claim that they had significant loss of income, with about a quarter of them dropping over $25,000 in personal income in the prior year, and 17% with their spouse income loss over $20K. From the Mayo Clinic standpoint, their assessment was that the degree of disability is comparable to congestive heart failure and chronic obstructive pulmonary disease. And this is further compounded because very few providers care for these patients, as has been mentioned before. The wait list to see POTS specialists is 6 to 36 months. It's about 4 to 6 months to get in to see me. One of the adult providers whom I know, 4 years. 4 years. Half of patients in the big POTS from Dysautonomia International, travel more than 100 miles from their home to see the specialist for care. It's not formally taught in medical schools. I certainly learned this not from medical school, not from residency in general pediatrics, not from pediatric cardiology fellowship. I just heard about it. I learned from friends, the medical literature, and on the job, and found an interest in it. So one thing I wanted to show you, since Dr. Cook came in uniform, I'm also former military. This is me as the chief of pediatric cardiology at Keesler Air Force Base in Biloxi, Mississippi. And this is where I learned about POTS, actually, after I had a patient who came to see me about 15 years ago who was not acting like the typical dizzy adolescent. And I said, I've heard of this POTS thing. I should maybe look into this. And I cold called this world expert, and we chatted on the phone for 2.5 hours, and the rest is history. Okay. So I want to thank you for your attention, and we're going to open up the floor for questions.
Right. So a subset of POTS patients have an identifiable underlying cause or contributing mechanism. I would guess maybe 20 to 30%. Maybe.
Plus minus. Yeah.
Or it was 20% having autoimmune and about a third having EDS, and we think that EDS may be the cause of those patients, but that leaves the vast majority of patients with no identifiable cause, and that's what we need the research to fund. That's what we need to figure out to help this huge patient population.
I think part of the other I think part of the other issue that goes with this that has at least handicapped us is that when we don't know how many there are of these patients, right? And so, you keep hearing this 1 to 3 million estimate, but it is an estimate only. And part of the problem is when we do what we do as physicians, we code the patient's diagnosis, right? And these codes, we use the International Classification of Diseases. We're now in the United States up to ICD-10, okay? So ICD-9 and ICD-10, neither of them have a code for POTS. The good news is we will actually have a code for ICD-11, but we just went live with ICD-10 like within the last 1 to 2 years, so heaven knows when we're going to go live with ICD-11.
And I like that question about with the heterogeneity of POTS and many things leading to this common syndrome. I think another way to conceptualize that, coming from my world as a neurologist, is epilepsy, so seizure disorders. Lots of things going on in the brain can lead to seizures. So if we diagnose someone with epilepsy, we say epilepsy due to X. Same thing with POTS. POTS due to an autonomic neuropathy from Sjogren's syndrome.
So the funding that we have so far from NIH has, up until very recently, has literally just been to sort of describe POTS. What is it? So the reason that chart starts at 1993 with the number of journal articles published is that Mayo Clinic first described POTS in its current form and its current definition in 1993. It's existed long before that. It's actually in the medical literature from the 1860s from Civil War surgeons describing it as soldier's heart, right? So it's been around a long time. And the research funding was primarily just to describe the illness. What is this? What is the blood pressure in these patients? What is the heart rate change when we put them on a tilt table test? So we just started getting very recently funding looking at like the molecular mechanisms that might be causing this. The National Heart, Lung, and Blood Institute funded a an antibody study at University of Oklahoma with Dr. David Kem, looking at autonomic nerve receptor antibodies that may be playing a role in POTS. So that's one area of research we're pretty excited about, but all of the things I listed were the areas that we think there is really great potential for new improvement. We want to not only improve treatment, we want to improve the treatment, but if we can improve the way we diagnose POTS and get people diagnosed faster, one way you could do that is if you had a blood test that could be a biomarker that this suggests this person has POTS, that for a lot of doctors makes it real, or makes it easier to diagnose. If they don't have a tilt table test, they might not know what to do with the patient. I don't know if you guys have something you want to add on that.
Yeah, as Ms. Stiles mentioned earlier, the repurposing of present drugs. I mean, she mentioned ivabradine as one of them, which is fairly newly released. But there's a lot of medications that I use in the pediatric population that I get a ton of pushback from the insurance companies because it's not listed as a viable use, right? So, for example, one of the symptoms or two of the symptoms that you've heard about are the severe fatigue, right? So these patients sleep 10 hours last night, wake up, feel like I haven't slept at all, okay? Or the brain fog. Smart kid, in class, understands what they're being taught, walks out of class, 5 minutes later, I have no idea what I just learned, right? So I've had actually very good success with the use of stimulants, right? So these kids don't have ADD, but Ritalin, Adderall, Vyvanse, Focalin, those medications do work in some patients. And I've got a manuscript that's being put together for that now. But I can't tell you the amount of time that I spend on the phone with insurance companies, between prior authorizations and peer-to-peer reviews and that kind of garbage, saying to them, look, what do you want me to treat them with? Because you put them on the medications that support their blood pressure, and that helps some, but they're still non-functional from that standpoint. So it is wide-ranging, the need.
Just sort of related to that, there's a push now for like precision medicine where we're trying to individualize what each patient needs. POTS is perfect for that type of approach to medicine because it is, my worst symptom was probably the GI dysmotility, which made me so ill if you lose that much weight and malnutrition. Other patients, their worst symptom might be just horrendous brain fog, cognitive impairment, where they can't think, they can't work, they can't go to school. And if you're, a college student and you have that, you have to drop out sometimes. So everyone's different. And I would love to see some of the precision medicine type funding going towards POTS. And really, as a nonprofit, our POTS video said we funded $408,000 in POTS research, but the video is a year old. So we've funded $585,000 in the past 4 years. And that's not a lot for medical research, but it's a lot for a little nonprofit that started 5 years ago. And we put out a request for proposals to the small number of experts who really do good research in this. And we said, if we had $100,000 grants available, what would you propose? Would that be worth it? And they wrote back to us, this was just our board members, just like maybe 10 doctors. They wrote back with $2.2 million in $100,000 applications. So I was like, okay, I guess we need to raise more. But we're hoping that that NIH will be able to do more than that. We did find out that some NIH report language was the appropriations bill had report language attached to it that encouraged NIH to stimulate the field of POTS research. And I hope that is in, I'm not an expert in how the legislative process works, even though I'm an attorney, but I'm hoping it stays in the House bill and gets passed and ultimately is something that NIH is able to increase its focus on. Yeah.
So maybe I'll just repeat that for those that maybe were in the back and couldn't hear. The comment was about some of the drawbacks of getting too precise, or if I could even add my own words, too granular in the way we try to describe or code things. The comment was that if you have such a precise diagnosis attached with a very precise diagnosis code, that may limit payers from reimbursing for certain procedures or treatments simply because there's nothing listed under that very precise diagnosis and diagnosis code. And certainly there is a drawback to granularity, but I would say those are systems of our own making, and we need not to be held prisoners to the systems of our own making. I mean, we need to design smart systems. But I think that it definitely is something as we go forward to remain aware of and keep our eyes open to.
I notice that we're sort of starting to lose people. We're going till 1:30 here, but before anybody else leaves, I wanted to say we're definitely going to follow up with all of you. So I hope that you will, be able to work with us on. There are a lot of different things that need work, and maybe you have one or two things that you're interested in. But I think a really important part of this is raising awareness. I know that's not necessarily what Congress usually does, but if you could send out information to your constituents on this, or direct them to our website. I mean, all of our medical content is reviewed by the doctors on our board, and it's very accurate. And curepots.org is a quick, short version of our website link, because dysautonomiainternational.org is kind of long to remember. But that's just something I wanted to plug. We really could use your help with that. We have a lobby day every summer. We come to DC with about 120 patients and family members, and we've met with hundreds of offices over the past few years. So if you get a call next summer asking your office to meet with us, please take the call and meet with us. And the patients are always very grateful to have the opportunity to talk to the staffers and the members. And I don't know if you have anything else you want to add. I know you've kind of no.
I think we've sort of, in some ways, we've sort of been a little bit repetitive. You've heard a lot of the same thing over and over, and I think my question to you, as folks who work with the legislative branch, is what questions, or my question to you is, what things can we tell you that would help you do your job better to help us? I guess we did a good job then. Wow.
So I'm also feeling like part of this is just raising awareness. A lot of people, when you say dysautonomia or POTS, they look at you like, what? And I did too. I'd never heard of this before I'd been diagnosed with it. So hopefully, share this info with your colleagues. You heard of this thing. I can tell you, it's like you ever get a new car and you think you have like a unique car, and then you realize like everybody in your neighborhood has one of these? I got a red Jeep Wrangler, and I thought I was the only one. And then I'm driving on the highway and there's a red Jeep Wrangler, and there's a red Jeep Wrangler. And that's kind of what POTS has been for me. I never heard of this before. And after I was diagnosed, my neighbor's kid has it, and someone's niece has it, and the teacher at the school has it. So it's out there, and it's just not well known. We look at where autism was 30 years ago. Nobody heard of autism 30 years ago, except for maybe a handful of doctors that were treating it and the families that were affected. And then Autism Speaks and other organizations started up and really came here and made a lot of noise and did a lot of public relations work to get the popular media talking about it. And that's what we're trying to do with POTS and other forms of dysautonomia. There were a few advocacy organizations before us, but nobody was raising a lot of money and doing a lot of outreach. And that's our goal, is to kind of, as we say, keep making noise for turquoise. If you see the people wearing turquoise today, they're usually the patients. So, all right. Well, do we have any other questions? All right. So thank you guys all so much for coming. We really appreciate your time. And we'll be in touch very soon with some additional requests for favors. Thank you.
Thank you very much.